Yeah, I want to talk a little bit about the problems we have with temperature management in the ICU and give you some examples of what is necessary. And as I told you before, fever is really a common problem in the neuro ICU, and this is data from 2000, but it shows you that the percentage of fever is, well, roughly speaking, about 60% of all patients on the neuro ICU which have fever. It can be seizures, it can be whatever, spinal disease. Roughly speaking, 40% or 60% of those develop fever. And the longer they are on the ICU, the higher is the probability to have fever. And as a thumb rule, you can say everybody who is more than 10 or 12 days on an ICU will have episodes of fever. So it's pretty clear that this is something which we need to be aware of. And obviously we have to think of what fever really does harmful to the brain, and the ideas are numerous. It increases cerebral edema, it reduces cerebral blood flow, and by that its ischemic injury may be larger than without fever. So that is really a treatment target for us. And when you think of what you can do, you can first of all think of antipyretic drugs, which have obviously side effects, but they are on a low costs and are practicable to infuse or to give. But when you look at the data available, antipyretic drugs didn't show any benefit. And I'll show you the latest results from the PAS trial, which was the Dutch trial, which not only used an antipyretic, but it used prophylactic antibiosis for the management of patients with ischemic stroke, treated on a stroke unit. And what you see here is that there's really no difference between the treatment group with a cephalosporin third generation and controls. So there's no advantage, and I think nobody does it anymore, prophylactic antibiotic therapy in patients on the stroke unit or with head trauma or what else. Physical temperature control is another option which you all can think of, and well, this is really time consuming, and these are the old data, Stefan Meyer, Michael Diringer and others. And what you see is you can reduce fever burden, but with cooling blankets, it's really, really hard work for the nurses. And coming back to the other strategies, we have the option of surface cooling, which allows you a lot more effective to reduce body temperature, and endovascular cooling, which I already mentioned, is in my eyes the best way to achieve long-lasting and good manageable hypothermia. So for fever control, we need to have something which is practicable, tolerable, and reduces the fever burden. And obviously we need something which is also reducing the nursing intensity, and I think for that endovascular devices are more appropriate than the others. So hypothermia, you saw that. I won't to go too much into details, but what you should keep in mind that it is a complicated procedure, even though I mentioned that we should do it everywhere, but we should keep in mind that we need to have, as I said, a slow and fast cooling. We need to find the target temperatures, and the duration is also a point. But of course, with many of these cooling equipments, it may come to overcooling. It may come that you cannot control temperature sufficiently. So this is something which you absolutely have to avoid when you manage your patient with hypothermia. So again, thinking of that, it needs to be tolerable, it needs to have a good temperature control, and you need to avoid ICP rebounds, and by that have something which allows you sufficient rewarming. You have seen that, the methods, you have seen ice cold saline, head and neck cooling, all of this is pretty effective, but not for a longer time period. Endovascular cooling, as you see it here, that allows you really temperatures around the goal temperature of 33 degrees over periods of time like 60 hours or even 5 to 6 days, as in some instances. So it is something which plays a role. Something which also plays a role is obviously the patient. Though the bigger the patients are, the more difficult they are to cool. And you will find patients, especially in the Western countries, where you have 200 kilos, 250 kilos patients, which are almost impossible to cool with physical means. So you have to have cooling catheters. And what you see here is that you really have to have a strong power catheter to allow decent cooling the more heavy the patients are. We didn't talk about shivering. You have to have an idea of what you do with shivering. And for that, first of all, there's shivering scores, which allow you a bedside assessment. But obviously, you have to think of ways how you can really control shivering in your patients. Because when they shiver, that is for clear detrimental. So shivering is something which you need to avoid in patients with any kind of neuro injury. And the concept we use, and most of the other centers use nowadays, is a counter-warming for sedated and ventilated patients. That means you do an endovascular cooling and use a warming blanket over the patient for counter-warming, and that allows you in most of the cases to reduce the shivering really effectively and significantly compared to no counter-warming. Otherwise, you can use the pharmaceutical means to reduce shivering. First line is obviously meperidine and buspirone. You can use dexmedetomidine, which is pretty expensive, at least in Germany, and I'm sure it's expensive here as well. So most of us will use meperidine, while knowing that meperidine has side effects, nausea, vomiting, seizure induction, and. So you have to closely monitor the patient when you give higher doses of these substances. Buspirone, an alpha-2 antagonist, causes also nausea, headaches. Meperidine, as I said, sedation, dizziness. Dexmedetomidine, hypotension, and magnesium, something which is not that widely used anymore for the management of shivering. Temperature control, that's a question of how do we really control the patient. Obviously, the easiest and ready available is bladder temperature monitoring, which is sort of easy available. Rectal temperature is mostly inaccurate. Nobody uses pulmonary catheters anymore. What might be attractive is MR spectroscopy, for instance, for measuring brain temperature, and for those who have a Lycox monitor on board, you can measure brain temperature. So all of this is possible. As I said, endovascular cooling has, in my eyes, the benefit of better, really, management of temperature and allowing maintenance better than any of the others. Duration of hypothermia is always an issue. What we know is that clear fever has a negative impact, and the longer you do hypothermia, probably the better it is. still we have to know that we have many diseases where we need hypothermia not only for 24 hours, we may need it for, well, 72 hours, perhaps even a week in patients treated with subarachnoid hemorrhages, for instance. So it is something which is not settled at the moment of how long we really have to institute hypothermia. I mentioned to you the question of ICP rebound, though that means you have to rewarm slowly and actively and not allow passive rewarming, as I've shown here in this example. This is one of these patients where you see there is an ICP rebound with hypothermia, nice reduction of midline shift, and after or during rewarming you see again massive brain swelling, which may be a problem for the patient. So it's something which you have to keep in mind, that rewarming is really important. Well, the rebound phenomenon is something which is not only true for ischemic stroke, it's also true for head trauma patients, and that is something which I discussed in the last talk, on the previous talk. So it's, well, nowadays standard to allow active rewarming with a slow rewarming of 1 to 2 degrees as possible. One could think of concepts where you do hypothermia and rewarming on an individual dosing, I would say, and that's our colleagues from Zurich, Manuela Keller and others, and they use hypothermia for patients with poor grade aneurysms and subarachnoid hemorrhage. And what you see here is that the mean duration of hypothermia was 169 hours with a maximum of 16 days. So it's something which is extremely demanding. So and I think you can only use that for very, very selected patients with poor grade aneurysms and subarachnoid hemorrhages. So in conclusion, the technique and induction of hypothermia has advanced over the last years. So we have a lot more of technical developments compared to 10 years ago. Tolerability can be achieved with a decent anti-shivering management. And what we have to keep in mind, we don't have firm guidelines of how deep, how long we should do it. So it is still something which is a specific treatment which is necessary for the optimal neuroprotection and anti-edema therapy. And for all that, we need further studies. And I must say, when you start now with hypothermia, it is something which can be done in multi-center trials all over the countries. And I think that is also a good step, for instance, for the new built Neurocritical Care Society here in Brazil, where you can do lots of trials about different grades, different ways to administer hypothermia. Thank you very much.
In your experience, how do you proceed the technique of cooling the patient? When you use these devices, you also use saline with to achieve.
Well, we use we use a set of interventions. One is the preclinical intervention, or let's say the intervention in the emergency room, which is, for instance, ice cold saline infusion. That is something which starts with the infusion of petidin, and then you infuse ice cold saline to reduce the body temperature. Then you do imaging, whatever you need, like in stroke patients, thrombolysis or thrombectomy. And then the patient goes to the ICU and is in certain cases then treated with the catheter for maintenance of hypothermia. So it's a complete, pathway for them.
And how long does it take to make to start the cooling with the catheter? And
that is pretty straightforward. So what you need is you need to set up the device, which is a cooling bath, and before you hook the patient to the catheter, it takes something like 30 minutes.
Okay, 30 minutes.
So it's for the nerve. Usually we use this device and we call it little sheep, because it has this notion of being a small sheep, and the nurses start with that when we say, well, we have a patient for hypothermia, then we make the little sheep ready for the going out on the what's Weide, or out in the green to cool.
I have a question about a paper that you didn't mention about the trial in meningitis, because the results was absolutely.
Yeah.
Can you speak a little about this
Yeah,
trial?
I mean, no, there's nothing to talk about this trial. This is a complete shit.
Yeah.
Just to say it directly. I mean,
Complete shit.
this
Okay.
is, no, I must say, the trial mixes up different things, different indications, and the idea was the concept is not bad. It would be interesting to reduce body temperature in patients with severe meningitis, but they mixed up several things. There were several specimens, there were different indications, there were patients with elevated ICP, there were patients with no elevated ICP, and the bottom line is, if you do a trial like this, it has to be negative. Fortunately enough, it was negative, but not for the patients, because they suffered on that.
Okay. Questions?
I have a question.
Okay.
Professor, in regard to many institutions here in Brazil does not have the device available to use it, and you still have the indications of those patients for hypothermia. Do you would say that you still have to use it using saline, trying to maintain with many variations of temperature, or do you would agree with only some indications, level 1 of evidence, and try to other one not use it?
No, I must clearly say you should clearly do hypothermia in patients with cardiac arrest, and there's no excuse for that. I mean, it's now on the guidelines for many years, and even though you say, well, we don't have the devices, I'm sure you can get ice bags somewhere. So I'm pretty sure that this is something which you should do. I'm not talking about ischemic stroke. There it is sort of a rather vague indication, and I think one can think of head trauma patients, especially for those where you don't have any option to reduce ICP when they are on the unit. So I think these, in my eyes, are the two main things where you should have it available, no matter whether you have a device or not.
And about the velocity of induction and rewarming, I work in a unit where we have a high prevalence of fever, neurosurgical patients. And we know that 1/3 of those fevers are related to the CNS. Do you think, and we tend to use like bromocriptine, stuff like that to try to control. Do you think that some oral dopamine agonists could be used as a tool to try to control this variation of temperature?
It's a difficult question. I mean, I know that some institutions use it, but I would say I'm not sure what you do. I mean, in my eyes, the physical reduction of body temperature is less, has less side effects than all of a sudden infuse bromocriptine or something to the patient. So I would say perhaps this can be used, but I would say for the reliability and management, physical means to reduce body temperature are more effective.
I think for us that we don't have these devices, I think that the main question is the rewarming phase, because we know that when we don't take the righteous care with the rewarming phase, we can screw up every work that we made. So for us, it's very difficult. Start cooling the patient, and then the rewarming. It's very difficult. The controlling of rewarming.
Well, I would answer in these initial trials, they didn't have any idea about rewarming 15 years ago, and they were highly effective. So I wouldn't go for the question of, well, rewarming is an issue, and I agree with you, but the argument, better not do it because we cannot rewarm, is in my eyes not valid.
Yesterday, Professor, you mentioned something about subarachnoid hemorrhage. In regard to those patients and vasospasm, would you tend to say that hypothermia would be used only for the poor grade patients, or we should use for every patient with vasospasm and subarachnoid hemorrhage?
Well, it's a difficult question. I mean, usually we use it in those patients who are ventilated and have severe vasospasm with neurological deficits. But of course, you could think of doing that for all kinds of vasospasm. But I must say, at the moment, the data or the evidence for that is rather low. So I would start with those poor grade hemorrhages where you have really nothing else to offer.
Since we're trying to set up a very fast service, as we talked before in this hospital, and try to figure out, the fastest way to get the patients to thrombolysis, when the ICTUS trial, if it comes back positive, where do we fit the ice cold saline in this rush to get the TPA on board? Would that come before the TPA?
It would come before the TPA.
That's what you do at your institution?
Yeah. So ideally, it would go like, patient comes to the emergency room, you see it's a stroke syndrome. It can be hemorrhage, it can be even a seizure, it can be ischemic stroke. Then you have the pressure bags, infusion of ice cold saline, and then they go with the pressure bags to the imaging. And then you say, well, this is ischemia, then you start with TPA.
How much or how deep you sedate the patient, and what's the exactly time to start waking up the patient. And if you use neuromuscular blocker every time you see
we don't
kind
use
of
neuromuscular blockers anymore.
Oh.
So that is
Shivering, rather.
Yeah, actually, neuromuscular blockers were one part of the problem when we had these high rates of pneumonias, I would say. And we found that it is not necessary to do neuromuscular blockade. So usually these are patients who are on a standard regimen of sedation, like you use propofol and benzodiazepine or whatever. And when do we start to wake them up? Yeah. After the cardiac arrest, usually we do the rewarming, as I described, 24 hours of cooling and then slowly rewarming. That is 48 hours, and after that we try to taper the sedation. And that's what everybody, I think, would agree on. You do the neurological prognostication after 72 hours after the insult, roughly speaking. And then you look for SCPs and brainstem reflexes and these things. And what I think is really important, don't use NSE in patients with hypothermia, because you cannot use it. It gives you pretty wrong idea.
Professor,
You keep monitoring the EEG of patients.
Yes, more or less, yes. We have contact to Sinapse. No, but yes, of course, you have to look for subtle non-convulsive seizures.
Professor, with regard to MCA infarction, large MCA infarctions and cardiectomy, I always thought that the one of the benefits maybe of craniectomy should be related to the temperature of the brain, since you take out the bone flat.
Could be, yeah.
Yeah. From the perspective of observational study, have you any information about it, about temperature of the brain on craniectomy?
Actually, only in animals. There are some studies which show that the parts, perhaps, of the benefit of craniectomy in rats, for instance, comes to the reduction of brain temperature. But not in. I'm not aware of human studies, but it well could be. But it's difficult to measure the brain temperature there, because usually you have with the removal of the bone, you don't insert another probe. So, but it could be. Yeah.
So I have a question that I'm always curious. What do you guys do? And I wanted to ask also these guys how they do here and how they have been doing with in-hospital cardiac arrest. So when the patient is a post-op or treating something like sepsis, then he arrests, but for an electrical reason or something like that. Do you cool these patients?
Yeah. I mean, that's a real critical question, because the in-house cardiac arrests tend to do even worse than the out-of-hospital arrests. And the reason is exactly because most of us don't follow the same protocols, because then we say, well, we have them under control, and so in our hospital we try to treat them. But I know, and all of you probably would agree, that it comes to my mind several patients where we did it the other way. So yeah, try to cool them.
Yeah, we say we do cool them.
Yeah.
But you start remembering.
No, the problem is you say, well, we had them. The ROC is the return of spontaneous circulation, and I did the resuscitation, and everything was just brilliant. When I do it, it's better than anybody else, and that's the reason why then the people are not treated sufficiently, because you overestimate the success of your return of spontaneous circulation compared to the paramedics, for instance. So I really must say you should follow the same protocol.
Yeah, I agree, but the thing is, I think that there's lack of awareness.
Absolutely.
To the treatment. So if the patient codes at night, the doctor that is resuscitating, he doesn't think about it, you're going to hear about it 6 a.m.
Exactly, and you're absolutely right. And I mean, it comes to the point that you have some patients where you think, well, should we really treat this guy because he has a brain tumor or whatever? And I always say, no matter what the underlying disease is, we start with the treatment, and we can discuss afterwards whether we may withdraw therapy due to whatever, but please start according to the protocol.
Also, the species you have a confounding issue that they're usually sedated.
Yeah.
So the premise of hypothermia, having the patient not coming back to full consciousness,
That's true.
that's lost. So
Yeah.
you
You're
either
right.
treat everybody or you don't treat.
Exactly.
And also the side effects. I think that the physician always think, oh, well, try, but the patient's so unstable and still using vasopressors, amines, and I think that probably the cooling will worse. So I think we must change the way that we have to look this patient. And
Absolutely. I mean, you should have one protocol which really fits the overall patient with cardiac arrest. And you should follow that no matter whether it's in hospital, out of hospital, atrial ventricular fibrillation, asystole, and you have time for withdrawal of therapy over the next 24 or 48 hours. So it's nothing which really changes the game completely. So it's just follow the protocol.
We usually overestimate the side effects of especially hypothermia for cardiac arrest. So when we talk about 24 hours of hypothermia, it's actually, even without the devices, it's not difficult to do. I mean, rewarming is an issue, of course, it's always going to be, but 24 hours with ice and ice saline, it's okay, it's easy to get there.
Yeah.
And we don't see as often as people say coagulopathy. Infection is more frequent, but 24 hours is a short time, and arrhythmias with this kind of temperature. Even yesterday, someone mentioned Nicholas from the TTM trial saying that if you want to deal with coagulopathy, arrhythmia, and infection, so you can do it. But if you look at the TTM trial, less than 5% of the patients have any of these side effects.
Absolutely.
So even he didn't experience it. So.
No, I mean, what you have to keep in mind, there's one study, I think it's also from Kim, who did this infusion of ice-cold saline in patients with an ejection fraction of below 20. And you would think, oh, this is might be a problem, but none of those had a problem. So it is something which is also possible for unstable cardiac patients.
O efeito adverso na hipotermia, né, no caso da hipotermia superficial, existem vários, queimaduras, as lesões subcutâneas. Uma delas é um efeito sanguíneo, que é a leucopenia e as coagulopatias. No caso, ele mostrou o superficial e mostrou também o tratamento agora com o catéter, né, que é o catéter venoso, femoral, tanto faz. Eu queria saber se com o catéter existe também essa leucopenia, essa coagulopatia, existe a probabilidade também de ter. É claro que a dermatológica não vai existir, mas eu queria saber se a sanguínea, esse efeito adverso sanguíneo vai ter.
But that's important. I mean, the device itself is not an issue. You insert it like a normal catheter, so it's nothing. The cooling, if you have a underlying severe coagulopathy, it may be that it's a problem. But I mean, usually temperatures of 33 degrees are pretty well tolerated. So there's nothing which you should be worried about.
But is there any difference between the surface cooling and the catheter cooling in regard to those side effects? She's asking.
Now, there is no trial which had a head-to-head comparison. I would say, obviously, the non-invasive surface cooling may have a little bit less side effects, which is due to the catheter. But otherwise, I'm not aware of any comparison here.
So shivering between surface and intravascular.
Yeah,
what's the
there's
difference?
clear that endovascular management is easier for the management of shivering, because with the surface you have all the parts where you have this brown fat tissue which is responsible for the shivering is covered already with the cooling pads. So it's a lot more difficult to do, for instance, counter warming for those patients.
Any question? No more? Professor, thank you very much. I think that was a great opportunity for all to learn about this technique. And I think the message is keep calm, keep cool. Thank you very much.
Thank you.